advance the slides?
Correct.
Okay, great. Well, why don't we get started then? I don't think it'll be a huge turnout today, but I'm sure there'll be a few more people and they can always catch up. So for those of you who are on the call already, welcome. Again, this is Patrick Jones, the director of the Public Policy and Economics Institute at Eastern Washington University, and a person who's been with Greater Health Now since 2014, serving in a variety of roles. And today we are going to have a brief meeting, on not a one that extends to 2 or 2.5 hours like we typically do, for a couple of different reasons. The arrangement that Greater Health Now has with the Healthcare Authority is still being worked out, and so Sharon Brown, our fearless executive director, did not want to put too much on the table until she has a little more clarity about what is going to actually transpire in 2024. So this agenda has shrunk a little bit, but the major part is from yours truly on looking at a data dashboard that my shop at Eastern has put together for Greater Health Now over the last 2 years. And I think we've just touched on it in one meeting in the past, ever so briefly, and this is an opportunity to take a little deeper dive into what is being measured about the progress in the Medicaid population in the 9 counties that constitute Greater Health Now. And then you can see that we will have an introduction of many of the new team members, if not all of the new team members, from Amber Henderson, and then we'll wrap up with any Q&A that people may have about future Leadership Council meetings. So with that, Martine, do you want to add anything about housekeeping?
If you're not talking, if you can please mute yourself so that we don't interrupt the speakers, that would be great. And the meeting is being recorded and it will be up on our website as well.
Okay, thank you, Martine. All right, the land acknowledgement, as I think all of you who have been here before know, we try to ask different participants to just read this brief statement that has been part of Greater Health Now for at least 3 or 4 years. So is there a volunteer who would like to briefly go over the text for our land acknowledgement statement to the tribes of this area?
Patrick, I can do it.
Okay, Sharon, thank you.
We should take a moment to acknowledge that the land on which we live, work, and play contain the archaeological resources and tangible evidence of Indigenous peoples. It is the historic homelands of the Yakima, Wanapum, Nez Perce, Colville, and Umatilla people who remain committed stewards of this land, cherishing it and protecting it as instructed by elders through generations. We are honored and grateful to be here today on their traditional lands. We give thanks to the legacy of the original people, their lives, and their descendants.
And thank you so much. And words well said. Okay, this will be up in a bit, right? In 2 or 3 days, Martine?
Correct.
Okay. Well, let's dive right into it and talk about these trends, this data dashboard that we put together. And you're going to see two parts to this. This is something that our shop worked out with the staff, as I said, at least a couple of years ago, in looking at just a selection of the indicators that are tracked by the Healthcare Authority for all the ACHs in the state. And this comes from the Healthier Washington dashboard, although we're taking deeper dives than what is typically on the Healthier Washington dashboard, because we're looking at subpopulations throughout the 9 counties in this particular dimension of the dashboard. So next slide, please. I just wanted to point out that we would obviously like to have as current data as possible. As you saw on the title page, this is through the 3rd quarter of last year. And that's as current as we have it from the Healthcare Authority. We'll get the end of the year results for 2022 probably next month. And we'll certainly have them posted to the dashboard. So overall, for the measures that were chosen by the staff, there were 6. Hospital readmissions rate, HA1C testing, sort of high number of visits to the ED, and then follow-ups after an ED visit for a couple of different conditions, and then something is known as mental health treatment penetration. We're going to just cover 2 of those. These dashboards are pretty lengthy, so in the interest of time, we're just going to cover 2 of those, and those are the first 2, the all-cause hospital readmissions rate and the comprehensive diabetes care H8-1C testing. And you can see here, these are the way we slice and dice the data. We are looking at different characteristics, age, ethnicity, race, and then a variety of co-occurring conditions you can see there. And when we talk about overall population, I just wanted to point out that this is the Medicaid population, not the general population. But for those of you who probably have a sense of how big that is, it's probably about 1/3 of the insured lives in the 9 counties. So it is quite substantial. Next slide, please. Okay, so this is kind of a busy one. They'll get less busy as we go on, but we're going to look at the hospital readmissions rate, and this, in a sense, is a measure of effectiveness of care within the hospitals in our region, as well as a measure of the level of chronic conditions by our Medicaid population in the 9 counties. And so you can see the definition there is readmissions rate that happens within 30 days that is unplanned. Now, we break this down into the 5, well, we don't, but Healthier Washington breaks this down into 5 population areas, and it's pretty messy, but I'll walk you through it real quickly. The dotted line, by the way, is the overall rate, which you'll see a little bit better, but maybe you can make out that it's gone from 9.6% to 12.2%. So higher is not better here. We'd like this to go down. We'd like the readmissions rate in a perfect world to probably be in the very low single digits. This has not been the case. And I'll just also point out again, what you're reading on the horizontal axis they're indicated as quarters. So starting out in 2019 Q2 all the way to 2022 Q3, but these are actually years. These are a year that ends in 2019 Q2 and a year that ends in 2022. So The punchline here is that we have currently the lowest readmissions rates, which is the blue line, the red line, with our young people, and we have the highest readmissions rate currently with what you might call just sort of middle of the age distribution, 45 to 54. So quite a bit of difference depending on whether you're younger or older throughout the 9 counties. Next slide, please. So this is looking at ethnicity. There'll be another one about race coming up shortly. And ethnicity is essentially looking at Hispanics and then non-Hispanic whites. Hispanics being in blue and non-Hispanic whites being in red. And you can see that for the 9 counties, the Hispanic share of readmits, or the Hispanic rate, I'm sorry, of readmissions into the hospitals has actually been lower than the overall average, and also since the non-Hispanic whites is higher, lower than the non-Hispanic whites as well. Might come as a surprise to certain people that this is the way the data show readmissions in our hospitals. Hispanics do not have a higher rate of readmissions than the, if you will, the dominant population group in the area. Next slide, please. Again, apologies for the messy graph. Again, we're trying to capture so much of the complexity of life in the US and in our 9 counties through the lens of race. So we have American Indian, Alaska Native, we have Blacks, we have Asian Americans, and then we have all others. And you can clearly see here that the lowest rates are currently American Indian, Alaska Natives. The highest rates are Blacks and all other, which is 2 or more races, which includes Native Hawaiian Pacific Islanders. I saw a note in the chat about why the rate is going up. And I think that's a question that I don't have an answer for, but maybe other people on the call have some thoughts on why the readmissions rate is going up over time. I just will point out that, of course, this does capture the COVID era, or the height of the COVID epidemic. But let me just pause here and ask whether people do have thoughts on why the rate may be going up. Anybody?
Hi, this is Lisa from Yakima Valley Farm Workers, and I know that in the Yakima area, primary care access is a huge issue. So perhaps the patients aren't able to get in for follow-up appointments and are then finding themselves readmitted.
Okay, yeah, hadn't thought about that, Lisa. That's good. They just lack of access is putting people back into the hospital, is what you're saying. Any other thoughts before we go on? You're going to see a few more. Okay,
Patrick,
Sarah.
yeah,
Did you
Patrick,
want to
this
say
is
something? Or
Patrick.
Becky?
Patrick, this is Becky. I was just going to concur with Sarah and all my clinical colleagues on the call. Certainly, length of stay are getting shorter and shorter, and we have, there's just such a market trend for insurances and utilizations to not keep people in the hospital, so people are really getting discharged quite soon. And also, as more and more Medicare and CMS moves for bundled payments, so our total joints, a total hip and total knee are same-day surgeries now. So if you are happen to have comorbidities or not the best social support at home or network, and you're going home with a major joint replacement the same day, any sort of complication, you can easily bounce back. So I think it's a perfect storm of many, many variables that we all are well aware of.
I think it's people not following through with recommended discharge plans too. When you have somebody that says, hey, you need to go to a SNF or you need to go to a rehab stay, and the patient says, no, I don't, and they're discharged home, right? Then they're setting themselves up for a readmit. So there's that. I think a lot of patients probably don't have the literacy or the cognitive ability to follow discharge plans, or they're not set up with home health to help them, you know, do their set up their medications and everything. I think it's a big. I think a lot of it comes from a discharge standpoint too, and the patient not being willing to participate in the recommended discharge plan.
Okay, good thoughts. I hadn't come up with those ideas, but I think they're pretty compelling. Any quick questions or quick
Sharon had her
comments before
hand
we move on?
up, Patrick.
Pardon me?
Sharon has her hand up.
Sharon.
Hi, Patrick. I wanted to ask Cody a follow-on question. Cody, do you think that if some of the people are getting discharged with a recommendation to go to a SNF or something, that there just isn't space available at the SNF, or is it just that there's no community health worker that's guiding them through that process, or do you think there's other mitigating factors?
I think it's both. I think that I know for a long time, and I'm not sure, you know, what the local staffing is, but our SNFs here for a long time, they were full, not based on physical capacity of the building. They were full based on what the staffing could actually take. So you didn't have the available beds to be staffed. So therefore they couldn't actually take in more patients. And then you have patients, I feel, that they have the fear that once they go to a rehab or they go to, and I think rehab probably has a negative connotation, you know, where, what do you mean I'm going to go to rehab? I don't have a problem with alcohol. I don't have a problem with drugs or whatnot, versus like a physical rehab place or, you know, whatever. So I think there's a block there. I think that there's, you know, the thought of people, once they go to a SNF, they're at a SNF forever and they're never going to return home. So they don't want to participate, even going for a little while is, you know, kind of one of the things I see. And then, you know, I'm sitting here reading through some Epic stuff on patients that I work with, and a lot of people just simply don't want to go, because if I go to rehab or I go to SNF, guess what? I can't get my alcohol. I can't, you know, versus, you know what, you just discharge me out and it's easier for me to go get my hurricanes or my earthquake beers and things like that. So.
Wow, good conversation.
So a SNF is a skilled nursing facility.
Okay, before we move on to co-occurring or comorbidities that accompany readmissions rate, which may say clear up some of this, I just want to point out that looking at ethnicity, looking at race, looking at age, there's considerable variation among the different groups compared to the overall average. So I don't know if that's a surprise, but it's something that we'll continue to track, and I think it offers opportunities for whoever the parties are for intervention to focus on some of these groups. The other thing I'll just point out, sort of to state the obvious, is that the sort of the major justification that HCA has made to Health and Human Services for a waiver, whether it's version 1.0 or 2.0, is that we will control cost. These are cost drivers with readmits, so don't need to see these going in this direction. Okay, next slide, please. So we have these different conditions, and again, the dotted line is the overall rate, and the blue line is the rate for that particular condition. And then the green line was an attempt to give a state overall benchmark, which we abandoned because we couldn't get the data. So just know that if we could get the data, we'd have a state benchmark as well. But for folks with any mental health need, and you can read the definition there, their readmit rate was a little bit higher than the overall rate over the entire length of time that we're measuring this for the 9 counties. And by the way, there were many other comorbidities or other co-occurring conditions that were available to measure, but this is what the staff came up with. So the first is patients with any mental health need. Next slide, please. The next is sort of a variant of that, but definitely the most significant portion of people with any mental health need is depression or anxiety. So you can see that that rate is also above the overall rate for the entire population in the 9 counties, and about the same levels, 14.5%. Most recently, 1 out of every 7, in other words, of people with a diagnosis of depression and anxiety found themselves readmitted after they had been in the hospital. Next slide, please. Okay, those with a diabetes diagnosis were also more likely to be readmitted after a stay at the hospital within a 30-day period. And you can see that rate has been about constant, a little bit higher than it was for anxiety, depression. Next slide, please. And cardiovascular risk, whether it's definitely not a high cardiovascular risk, it's people with very low or medium risk. It's very close to the overall rate, so not much opportunity there, I think, for intervention. Next slide, please. Another variant of those with any mental health need is psychotic illness, bipolar diagnosis. Again, about the way it was for the first slide you saw on any mental health need, about 16% most recently, and that means 1 out of every 6 patients with that particular diagnosis is being readmitted. And somebody just put up on the chat, will these slides be available? And Martine, I think they will, right?
Correct, yes.
Okay, just in the interest of moving on. Next slide, please. Hyperlipidemia, very similar to cardiovascular risk, not as high as those with any mental or behavioral needs. And you can see it's currently about 14%. So, and it has come down. This is one of the few that has come down. So if you have a diagnosis with hyperlipidemia, slightly higher than a chance that you'll be, or probability that you'll be readmitted. Next slide, please. So this just summarizes those subpopulations that have the highest risk of being readmitted. And by that, we mean it's greater than the average adults in that age group, whites, Black or other races, and all other races, and then almost all, in fact, all the co-occurring conditions that were identified to track. All right, let's go on to the second look, and this is measuring the share of the people who have received a diagnosis as being diabetic, whether it's type 1 or type 2, who have been tested in the course of a year at least once with an HA1C. And the dotted line is the overall rate. You can see it starts out at about 82.5%, but falls over the course of the 3 years that we're looking at to by 3 percentage points. Again, a trend in the wrong direction. You can see that the age groups that have had constantly the lowest share of testing are going to be the youngest, and that the shares in blue, sort of a mid-blue and a yellow, that have higher than average shares are the older group. So I'm certainly no clinical expert. Those of you who are, you may nod your head or maybe shake your head, but looks like older people are getting with the program, so to speak, a little better than the younger people. Next slide, please. Again, this might surprise people, but Hispanics generally, although the share has declined, Hispanics have a better overall record of taking the HA1C test than non-Hispanic whites. Next slide, please. And then by race, again, this does not include whites. So all, if you will, the people of color groups are currently below the overall average, with blacks being the lowest, and the rates have come down. So let's just pause here real quickly. So looking at race and ethnicity and age, any surprises there? For those of you who care about administering diabetes care, which I think is something that you'll hear from Greater Health Now going forward as a priority. So, you know, we ought to pay close attention to these numbers. Okay, so no surprises, I guess. All right, well, let's go into the co-occurring conditions. So if you have any particular mental health need, you will get, or you have gotten, and you're a Medicaid patient in the 9 counties, you have gotten HA1C test at higher rates than the overall population. It's stayed about the same. Next slide, please. If you have a diagnosis of depression or anxiety, again, just like those with the general category of any mental health need, you're being tested at a higher rate than the overall average. And you're diabetic, excuse me. Okay, next slide, please. Now, no surprise here, if you're diabetic, if you've got that diagnosis, you are being tested at higher rates than the overall average. They're at 86% most recently. No surprise there. Next one, please. Cardiovascular risk, also about the same at 86% currently, higher than the overall average. Next slide, please. Psychotic illness, not a big difference to the overall average. You can see slightly higher now than it started out to be. So it's a small population, however. Next slide, please. And by the way, the bars give the population levels if you wanted to test that out. Next slide, please. And then hyperlipidemia, no surprise here. If for me anyway, if you have a diagnosis of hyperlipidemia, you are getting tested for diabetes at a higher rate. Okay, so here, in contrast to the readmit rates, the subpopulations that sort of stand out at higher risk is a much smaller list than what you saw. So young adults and adults in the category of 18 to 2 categories there up to age 44. If you're white alone, in other words, not Hispanic, you're at higher risk, and blacks, you're at higher risk. So that's once over lightly for 2 of the measures that we were asked to track over all 9 counties. Now, perhaps for those of you on the line, this next part of the presentation is of greater interest because this looks at some key performance indicators, in particular 2, by each of the 9 counties. So sort of following the adage from Speaker O'Neill once upon a time that all politics is local, so all health care concerns might be of higher interest if they're local. We're drilling down now to the counties. The difference here to what I showed you is that we're a quarter behind, and it's not due to our shop, but it's due to HCA having some computer migration issues. As they explained to me about a month ago, I was hoping that we would have been able to update these through Q3. that just wasn't the case. So this was done in the summer, and you haven't seen them though, so I hope it will be of some interest to you. Next slide, please. So again, the different measures, and we've covered the first two overall. And now we're going to look at all-cause ED visits and a follow-up after an ED visit for mental illness. So in other words, the middle of the list there, and we're comparing each county to the Greater Health Now overall average. Next slide. So all-cause ED visits. I think we all know that this has been a focus of the Medicaid transformation program. Is we'd like to find alternatives to the ED, and this. Sarah, I'll send you offline just what a follow-up is, but it's not too well defined. But a follow-up would be, in general, something that a message, a inquiry that comes either from the ED itself or from a provider associated with the patient. So Asotin County, you can see, has had a much different experience than the overall average, and this relative quite high rate of ED visits is puzzling to me. And I don't know if there's anybody from Asotin County on the line. The only thing I can come up with is that perhaps we're somehow measuring folks in Lewiston or in the Idaho part of this catchment area in Asotin County as well. I don't know. But you can see overall, the dotted line of all-cause ED visits declined until the year that ended in the first quarter of 2021. So it declined a little bit up until sort of midway through the pandemic. And then over time, the rate has steadily, slowly, but surely crept up. So started out at 63 per 1,000 member months, and the overall average is most recently at 47 per member months after hitting below 40 per 1,000 member months. So this is really the one outlier you'll see among all the counties. Let's go on to the next one. You can see that for Benton County, the track of ED visits closely follows the overall average. Next slide, please. The track for Columbia County since the trough here in the first quarter of 2021 follows the overall average quite closely. Next slide, please. This, for me, was a surprise. I don't know about you, but the path of Franklin County rate of ED visits has been consistently below the overall 9-county average. And it followed the same pattern. Okay. Next slide, please. On the other hand, Garfield, which of course is a very small county with slightly over 2,000 people, and I don't know what the Medicaid population is, but not big numbers. You can see that this was somewhat like Asotin County. Every measuring interval, it was above the 9-county average for emergency room visits. Next slide, please. Kittitas County is, along with Whitman, which you'll see here shortly, has been the county with consistently lower rates of ED utilization than the 9-county average, although it has crept up considerably over the measurement period and currently isn't too different from the overall average of 47 per 1,000 member months. Next slide, please. Walla Walla County also below the overall average consistently, and maybe even becoming consistently, or not consistently, but most recently lower than the overall average. The gap is growing, in other words, which if you're in Walla Walla, that's a good thing. And then finally, two more, Whitman County below the overall average. As I said, along with Kittitas County, and then now to some degree Walla Walla County, if you will, the better performers. And Yakima County, just about the same. So any quick thoughts for those of you in various counties about your experience in seeing emergency room visits decline among the Medicaid population? Obviously, this is a good
This is
thing.
Kim.
Hi, Kimberly.
This is Kim in Yakima County, and I am at Astoria Toppenish Hospital. We actually have an increase in our area. We are located on the reservation, and that is pretty much all that we typically see is the uninsured or the Medicare insured patients. So we actually have quite a spike of that, but that's really just indicative of our population here.
Okay. Yeah. Okay. And Danielle says, okay, well, first of all, let me take Bobby's. I work in Asotin County. I believe you're probably correct with Lewiston so close. Bobby, do you want to elaborate?
Yeah, I'm a community paramedic in Asotin County. I work for Clarkston Fire Department. I think you're probably correct. We are separated by a state border with Lewiston, but it's basically, we call it the Valley, but it's one community. And I frequently work with patients who go to Tri-State for emergency room needs, which is in Asotin County. And it goes both ways. You know, some of our patients head over to St. Joe's over in Lewiston, but I think that could be why those numbers are so different. I think you're correct on that.
Okay. And we all know there is a much different rate of Medicaid expansion in Idaho versus Washington, right?
Yeah.
Okay. And there was another comment real quickly from, what county was it?
Danielle from Kittitas County.
Okay, Danielle, you would like to elaborate?
Yeah, so when we transport people, a lot of times it's not to the Kittitas Valley Hospital. Depending on the severity, we're transporting over to the west side or to Yakima. So chances are the number of Kittitas County residents is actually significantly higher than what's being represented into the emergency department for Kittitas County.
Okay, you raise a good question. I don't know to what degree this database captures is looking at hospital data or looking at patient data. So I'll have to follow up on that. So you're saying it could be higher if the transfers were included.
Yeah, if we transported more individuals to the emergency department within Kittitas County, obviously those numbers would be much higher and lower in other counties. So
got it. Yeah. Okay.
Yeah, I think just like what Bobby said, you know, with Washington and Idaho, Walla Walla is also a border community with Oregon, and you know, not just the reimbursement rates, but also just the ability for somebody like myself who's certified as a paramedic in Washington State. I can't go see a patient in Oregon and do anything for them to help them or relieve that pressure off the hospital because I'm not certified in the state of Oregon. So there's definitely some problems with the border communities that, you know, those that are more central don't
Right.
have
Right.
to deal with.
Right. Okay. Thank you, Cody. And Sam, did you have a comment?
Yeah, I just had put in the chat that I'm curious about like hospital staffing or capacity, what and just what that data looks like in 2020 compared to now, and if that has an impact on those visits. I know this is specific to the Medicaid populations, but I would just be curious about like access in general and any impact that staffing capacity may have on access.
Okay. Any hospital folks want to weigh in on that question? Or ex-hospital folks like Becky Betts?
Yeah, this is Kim again. And I mean, staffing definitely is a huge issue. Pretty much everybody was short-staffed before the pandemic happened, and it just exacerbated the problem. So when we're looking at it being able to accept things, it's, we could have the bed, but not having that staffing member, and that's just really gotten a lot worse.
Okay. All right, thanks, Kim. All right, let's wrap up with the last measure, if you wouldn't mind. So this is measuring a follow-up within 7 days after a visit to the ED for mental illness. And the follow-up is related to their diagnosis of mental illness. Now, there's two measures here in Explore Washington or Healthier Washington. One's a 30-day visit, and one's a 7-day follow-up. And I'd say we, but I think it was the staff at Greater Health Now chose the more stringent, the more challenging measure of following up with 7 days. So this is looking at the state compared to the 9-county average. You can see that it's about the same. It's been falling, however, for both groups, but a little stronger for the 9 counties in the ACH, 61 to 54% over time. Okay, so let's look at then the counties compared to that. So in Soudan County, generally the follow-up has been below the 9-county average, except for the most recent reporting period, where it was nice to see it jump above the average. So it was 54 to 61%. Next slide, please. Benton County, however, has continued to slide. And so the follow-up has gone from 58% to 49%. And by the way, the two counties that really move the numbers are Benton, for the average, are Benton County and Yakima County. So next slide, please. Columbia County, a very small county. You know, we have less than 4,000 people in that county, and the Medicaid population is much less than that. So this has some instances where there's 100% follow-up, and one instance which you can see there where there was 0% follow-up in a particular 4-quarter period. But if I had to say, generally, it's been the rate has been above the 9-county average. Next slide, please. Okay, Franklin County started out below, moved up above, and now it's slightly below the 9-county average. And let me just throw in here the partner or sister measure to this is the follow-up after an ED visit for alcohol and substance abuse. Those numbers are much lower than what you're seeing here. You can see generally we're looking at a follow-up rate within 7 days in this 50 to 60% range. Follow-up for alcohol and drug abuse is in the 20 to 30% range. So not going to show that to you in the interest of time, but it is on the dashboard. So Franklin County a little below now, and again, Garfield County smaller yet than Columbia County, so we have instances of 0 follow-up, and we have a few instances of above average, but generally you'd have to say that it's below the 9-county average. Next slide, please. Kittitas County, keeping, if you will, with its outperformance from at least the measures that we've taken a peek at this morning, above the average, although it's been declining. You can see it started out way high at 80%, It's now slipped down to less than 60%, but still above the 9-county average for follow-ups for mental illness. Next slide, please. Walla Walla County, about the same. There was a period of outperformance for the early years, and now it's 56% versus the overall average of 54% within 7 days. Next slide, please. Whitman County, consistently, except for one reporting period, consistently above the overall average, although declining in concert with almost all the other counties that are part of the ACH. And last but not least, Yakima, below the overall average in terms of follow-up, but not too far below, pretty close. And there was a period of time when Yakima was above the overall average. Does your hospital have crisis counselors or mental health folks? And so this is a question from Nicole, and I'll just throw this out to people because, again, my question is why isn't this 80%? Why is it in the 60 or 50% for follow-up from ED? But I'm not a clinician in an emergency department. Any thoughts on why and why it's been declining a bit?
This is Kim. In Yakima County, I know one of our biggest things is the availability. Number one of, is there even a physician that the patient can follow up with? Do they have a physician to follow up with? If they don't, getting them to get with a mental health care provider, and it's just, there's not that many. And it's just hard to get them in.
Okay. All right. Thank you. Thank you. Rebecca says, this is what I see. Nicole, this question was to all hospitals. Any other hospital?
There was a comment from Sarah Patrick from Tri-State in Asylum County, and it says that they partner with Quality Behavioral Health to fill that need in the ED.
Okay. Okay. So that partnership, I'm sure, is important.
And many hospital systems are leveraging telehealth for those behavioral health needs or telepsych consults.
Okay. Well, that I would hope then, Becky, that means the rate goes up a bit over time, right? I don't know.
I think it's inconsistency in a lot of different things. Like, for instance, you can ask a DCR from, or designated crisis responder, for those that don't know, from the same, you can ask two from the same place. What are the rules? What are the procedures? And you can get two completely different answers. So, you can see somebody who, hey, we're going to detain this person. Okay, cool. I heard that they're 3 days and 5 day holds. Like, how long are we keeping this person? Well, they have to be reevaluated every 12 hours. Okay, so this is like a 12-hour hold, because right now this person is saying this because he's intoxicated, right? He's going to go to the hospital. He's going to sober up. And then the next DCR is going to come in to reevaluate him. And then that person's going to say, I was just drunk. And then they're going to say, oh, there's no crisis. Okay. And then you go and you get back on the same horse 12 hours later and get kicked in the teeth again. So you just consistently are in this cycle of crap, bureaucratic crap, where people can say that they're in crisis and then it doesn't meet somebody's criteria of crisis. So you can have people that define their own crisis, and then you can have other people that say, well, your crisis isn't that bad, so there's nothing I can do. And then you have people who actually do go to facilities and get treatment, and then they're released into your community without any follow-up plans at all, and then they kill themselves. We've had 2 people that's happened to within the last month. We had a veteran shoot themselves in the entrance of the VA grounds here at Walla Walla, very close to our children's museum, and the bullet passed through his head and hit a car that was driving onto the campus. And then we had another man who jumped off of our 2nd Street bridge and killed himself. And everybody who I've heard said that those were pretty predictable. So anyways.
Yeah, those are two sobering examples, Cody. Thank you.
I'd like to add to that because, that is something that we see consistently in our community in Toppenish, that we call for the DCRs, they come and evaluate the person. And we've been told literally, well, we don't have a room for them, so we're going to release them. Not the fact that the person needs to be detained or should be sent somewhere. And that's another thing. We have our own behavioral health unit here. We never get referrals. They never hold them to us. They always get sent to the facility in Yakima. It escapes my mind right now. We get
Bridges.
patients from yes, Bridges. We get patients from Spokane. They've come to a facility in the Yakima County somewhere. They have been detained. They have been sent to Spokane. And then Spokane calls us, hey, we're not sure why this is, but I think this is a better candidate for you guys. And we get those patients back. And it's just very inconsistent. And, honestly, there's a concern with the care. But you're right. The patient, there are the ones who are suffering from these.
Well, I think too, Senator Cantwell was here to talk about fentanyl a few weeks ago, and I was fortunate to be involved in that conversation. And Walla Walla, we're blessed to have the VA campus here, but we're also cursed. Like, the hardest person for a community health worker, myself, dealing with somebody in Walla Walla is a homeless alcoholic veteran. That should be the easiest person on the street for us to find resources for. It should be 100% the easiest, but it's the hardest. The US government has sent people to the moon and returned them to Earth, right? But we can't send a veteran to treatment. Even when we have a residential recovery unit right here on our campus in Walla Walla, like what's the magic potion to get people help? It's so incredibly frustrating.
Hey folks, this is Edie Dibble, Comprehensive Healthcare. I'm going to put my email address and phone number in the chat, and you guys reach out if you feel like it. There is regulations, WACs, RCWs on detainment, so there is strict criteria that they have to adhere to in order to ITA and take somebody's rights away. Kim, happy to talk to you. I know we've tried to place people in Astrea and we've gotten turned down. So we have reached out to everybody within the communities. Our Bridges unit is typically full because we don't have our ceiling unit open right now. And then we do start looking for beds out of the area if we can't get acceptance in the local area. So I think there's a lot of mixed messaging going on. And then
amongst comprehensive as well.
What's that?
Said including within comprehensive.
Correct.
It's not all of us that are misconstruing
Correct.
comprehensive. It's your people within comprehensive.
It's the community. I agree with you, Cody. And then I just want to say too, for admitting somebody into any of the facilities, whether it is Waypoint, which is residential and crisis stabilization, or whether it's an evaluation and treatment center, at least in most cases, providers have to follow medical necessity if there's a payer source. Otherwise, they're left holding the bag. But I'm going to put my contact information in there, and folks, feel free to reach out if you want.
Thank you.
So if somebody needs psychiatric help and they can't afford it because they don't have payer source, do they not get it? Is that?
No, we have all kinds of grants and other things that we do to help fund people's stay. We don't turn people away when they say they're in crisis.
But how long does it take to get those funds? Because if somebody's in crisis, like crisis is happening.
We wouldn't turn them away. If they show up at crisis stabilization and they're in crisis, even if they don't meet the detainment criteria. So if they don't meet detainment criteria, we wouldn't put them in our ENT.
I disagree with that. We had a man who said, I'm going to walk and jump in front of a truck, and our medic, one of the community medics, not myself, my colleague, says, okay, well, let me take you, get you some help. Where do you want to go? And he says, I want to go to Waypoint. I don't want to go to the ER. I do not want to go there. I go to the ER, they stick me in room 4, and they don't give me any help. So I want to go to Waypoint. So my colleague shows up at Waypoint with this guy who says, I'm going to jump in front of a truck and kill myself. He explains that to the staff and they say he has to go to the ED. My colleague says he doesn't want to go to the ED. If you send him to the ED, guess what? That's a trigger. He doesn't want to go. He wants to be here. And they said, sorry, we can't do anything. So the guy left and walked towards the highway where trucks were. Luckily, he didn't do it. But
So again, there's
So you
rules
do
and
turn people away.
regulations around detainment. And so Cody, if somebody is in crisis and that DCR does believe they're detainable, which I don't know the specific scenario of this person, but it sounds like there had to be a DCR evaluation. If they're heading down that road, they do have to have a physical health clearance, medical clearance, which does come from the ER. So to be admitted into Waypoint, that's not a detainable
But
facility.
you're not. They weren't even willing to talk to the person before they went to the ED.
If they didn't believe they were detainable, they could have easily admitted them there. But if they thought, or if first responders were saying they were in crisis and detainment was an option, they did need medical clearance. So again, I don't know the specifics, but happy to look into it.
So
Yeah, if you could do that, Edie, and others on the call.
I would need some client information. So Cody, I don't know, do you want to put your email in the chat, or you want to email me some specifics?
I'll do it right now.
Okay. And then
That'd be great.
if you email it to me, I'll dig into what happened with that particular one.
Okay. Yeah, in the interest of time, I think we need to shove on this. This has taken a little more time than Martina and I had booked for this, but I hope it's been helpful and raised some questions. And we will continue doing this, as far as I know, at future meetings with a little bit of sort of a slice of this at every session, not probably as much as you've seen today. So thank you so much. And let's move to just the second piece of business we have today, which is an introduction of new faces. That's not going to be by me. That's going to be by Amber, right?
Correct.
Patrick, I am going to introduce Amber, and Amber will introduce all the new
Okay.
faces.
All right. Very
But
good.
thank you so much to everyone for that very robust conversation, and definitely really needed conversation. Patrick, the data is just kind of gives me the chills a little bit. You know, I really wish we were moving in a better direction, but it's very sobering for us to see that data as we all work to addressing solutions and improvements going forward. So on a lighter note, it gives me great pleasure to introduce to you Amber Henderson. She is the Greater Health Now Chief People and Culture Officer. She has more than 20 years of experience in healthcare, human resources, and organizational development. She joined us from Virginia Mason, Seattle, and has previously held leadership roles at Yakima Valley Memorial Hospital and Memorial Physicians. Amber began her career at Yakima Valley Farm Workers. So to our colleagues from Yakima Valley Farm Workers on the call, thanks for bringing Amber along for us. We're really excited that she had that experience. She's currently a PhD candidate at Gonzaga, studying leadership studies. In her free time, she enjoys exploring the Pacific Northwest, watching professional and minor league baseball, and spending time with her family. We're very, very fortunate to have Amber on board. And Amber, take it away.
Thank you so much. And I do see some of my colleagues, previous colleagues on the line today. So hi to all of you who recognize me from previous employment engagements. So thank you, Sharon. So let's get started with Mattie Tomoe Palmater. She is our Region 3 Community Hub Liaison. She comes to us from Heritage University, where she trained on suicide prevention. And prior to Heritage University, she worked at OSU in the School of Nursing, where she focused on diversity recruitment as well as administration support. And then before that, she was at Pacific Northwest, Portland area Indian Health Board, where she coordinated the asthma management project in partnership with the Yakima Indian Health Clinic pharmacists to help reduce childhood asthma morbidity in the Northwest tribal communities. She identifies with both the Yakima Nation as well as the Confederated Tribes of Colville Reservation. And she is currently working on her Master of Public Administration with an emphasis in health administration. So we are very excited to have Maddie join us. She is one of three, and she has been our initial hire for this particular liaison position. And she has been tremendous at getting in and helping us create the robustness of this particular program and really helping support that. So she serves the Kittitas and Yakima counties. Next, we have Luis Santoyo Jr. He is one of our finance and contract coordinators. He comes to us from Goose Ridge Winery. He is a graduate from Tabor College, and he was actually a football player for them in the Division II series. So he enjoys lifting weights as well as cooking. And if you ever get a chance to work with Luis, he is probably just the most gentle soul you'll ever come into contact with. Just the kindest man. He has been just such a joy to bring on board and work with. So we're really grateful for him as well. And then next we have Jocelyn Martinez. She is serving as our administrative as well as our HR coordinator. She has a bachelor's degree in business administration, and she has several interests. She likes to hike and draw and paint. But her favorite activity is really her husband and her two little kiddos. Those little ones keep her busy. One key aspect about Jocelyn that we really appreciate is she really loves to learn. So she leans into anything and everything new that we ask her to do. And we're really grateful for just her positive attitude that she brings to the work that she does. And so if you're sending or calling in to Greater Health Now, more than likely you're going to be connecting with Jocelyn. So we are very excited to have her with us as well. Next, we have Amy Smith. Amy is our communications specialist. So she has over 20 years of experience in graphic design as well as marketing. And when we interviewed Amy for this particular position, she really blew us away with her work products and deliverables. And so we have been putting Amy to work and really using her talents in a lot of the work that we've got going on, as well as the work that we have coming up. So we're really excited about that. Amy enjoys reading, sculpting, paddleboard, spending time with her family, and then she self-confesses that she has two spoiled dogs at home that take up a lot of her time. Next, we have Kaylee Wade. Kaylee is one of our program managers, and before she joined us at Greater Health Now, she worked at Providence. She has a bachelor's degree in social work, and she has just this strong, and when you talk to Kaylee, you can feel her passion for helping others. And one of the key attributes in working with Kaylee is she brings this wealth of experience from the work that she did at Providence, and she's transferring that over into the work that she's doing with us at Greater Health Now. And she's just been a real joy to work with, and we're really grateful to have her. She likes to go outside, spend time outside. She likes mountain drives, family time, painting and cooking. So we're grateful to have Kaylee with us as well. And then finally, we have Nicole Matthews. Nicole is our manager of innovation. Before she joined us at Greater Health Now, she worked at the Kittitas County Health Network as a communities project director, which supported many cross-sector projects. So it's entirely possible that you've worked with Nicole in her previous position. She's also worked in the rapid rehousing programs, and she's been heavily involved in youth programs which support both the licensed childcare as well as the behavioral health services. She's currently working on her Master's of Science in the Nonprofit Administration program through LSU. And Nicole, if you've had an opportunity to work with her, she brings so much energy and joy to every single conversation. And she's a wealth of information as well. So it's just really, truly a joy to work with her. She enjoys spending time with her family. She talks about her family a lot. Sometimes we see her little kiddos, and it's really fun to see just how that all comes together for her. She also enjoys playing and discovering the world that we all exist within. And so, she really emulates that embodiment of inclusion and making sure that everyone feels like they're part of the team. So with that, I would like to say just a really warm welcome to the team that we brought on board in the last several months. And as we continue to grow and look at the work that we have ahead of us, I'm sure that we will have more team members that we'll be able to introduce to you. So thank you.
And I have one more that came in a little bit late, Amber. I got it this morning, so I added Maddie's on here as well.
Good. Okay. Well, we have Madison Grimm. So we have Matt T, and then we have Maddie. So Maddie is our manager of community-based care coordination here at Greater Health Now. She is a state and nationally certified medical assistant. Before joining us at Greater Health Now, she did work at Providence as well. So her and Kaylee have that experience together. She has been serving as Becky, in coordination with Becky, and working on this hub liaison project and a lot of the work that we have going on in that particular area. Excuse me. She also enjoys gardening, spending time with her dogs, and watching sports and fishing. And I know personally that Maddie enjoys the Gonzaga basketball team. So shout out to Gonzaga on that one. So yeah, welcome to Maddie as well. And I think, we might have some more coming up at our next meeting as well.
Thank you, Amber. That's quite a lineup, quite a team. And I know that Sharon's quite proud of them. And I'm sure we're going to be looking at great things in 2024 and beyond. Before we say goodbye, I'd just like to put Martine on the spot and ask, will there be a November meeting? I know there's not typically a December meeting, but will there be a November meeting?
There will be no November meeting, Patrick. We will reconvene internally and include you to plan out what 2024 will look like. Once we have that figured out, then we will send out a communication out to all of our people that are on our list to send out communications to, so be on the lookout for that.
Okay, but Martine, is it safe to say that we will be responsive to requests that come in about topics? So
Correct,
if somebody has some good ideas about what they'd like to see covered in a leadership council meeting?
Yes, so any ideas, feel free to reach out to one of us. Our information, I'll put in my email into the chat box. We're open to any topics that you guys want to hear as our partners out in the communities. So if there's a specific topic, please let us know.
Okay, good.
And Patrick, before we leave, I just want to give a shout out to another team member, Melissa, so she doesn't think that we forgot about her. We'll introduce Melissa to you all in January.
Right.
Wow. And we have Chase as well. I forgot.
Oh, right,
Chase. Did not send it in, so we'll introduce Chase during the next time.
So much growth, so many good things ahead. Thank you for being patient with us.
My head's spinning. I've got to come down and spend some time and get to know you all. All right. Well, that's it for today's meeting. Unless there's some last minute hands up for the good of the order. Any quick things you'd like to? Any participants online would like to bring up? Well, once again, thank you for attending. Thank you for your participation, and let us look forward to a great 2024 with the Medicaid Transformation Project version 2.0. So till then, and you'll be hearing from Martine, I'm sure, before then, right?
Yes. Correct.
Okay. Take care, everybody.
Thank you, Patrick.
Yeah, take care.